Good afternoons. Welcome back to this symposia sponsored by Abbott. It is titled Seeing is Believing, OCT-guided calcium modification in a complex PCI from King Saud Medical City, Riyadh, Saudi Arabia. The objective for this session is to learn about the role of OCT imaging in management of complex calcified coronary artery lesions, to learn indications of calcium modification using orbital atherectomy or other modalities based on findings on OCT, to learn optimization of DES expansion by OCT in complex calcified lesions. The session team, I'm honored to be joined with my colleague, Dr. John Fajadeh, Dr. Arif Al-Nouriani, Dr. Khalid Al-Marri, and Dr. Ronnie Shantouf. The operators are Dr. Hatem Alawi and Dr. Ayman Al-Husseini. We'll have the Cath Lab Medical Coordinator, Dr. Khalid Al-Harbi, Saudi Arabia, and on-stage Medical Coordinator, Ihab Sharif Sidqi from Bahrain. Please do interact with this session, with the panel, with the chair, and with the operators through the course mobile app, or stand up to the microphone to present your questions. We will communicate with the operators with your question. And now we'll go to John Fajadeh to present the case.
Good morning, ladies and gentlemen. Is it this one? Okay, sorry for that. So, the patient is the young patient, 45-year-old gentleman. This patient is diabetic with hypertension. The rest is of the presentation is quite normal. And he has quite a long history of coronary artery disease and intervention. The story starts in February 2020. He developed an STEMI. At that time, the ejection fraction was 45%. He had a moderate mid-LAD lesion, a subtotal stenosis of the left circumflex artery, and a plaque, intermediate plaque at 50% on the ramus. He underwent PCI of LCX with one DS implantation. 1 year later, he come back with, again, an STEMI. The ejection fraction was similar to the ejection fraction 1 year ago. He has a total in-stent thrombosis with a progression of the disease on the ramus with a critical lesion and a mild progression on the LAD. At that time, the PCI was he underwent PCI on the circumflex artery with one DEB and a DES to the ramus. Then it was followed by regularly by his cardiologic team. And last August, he came back with a stable angina, and the medical treatment was increased, but without any angiography or intervention. End of 30 October, no improvement of the symptoms. And so the cardiologist scheduled coronary angiography. Concerning the medical treatment, you could see that he has 10 medication, and even with that, beta blocker, isosorbide nitrate, perindopril, and he has still symptoms. Concerning the biology, no significant abnormality. Baseline ECG was quite normal, sinus rhythm. There was only negative T-well in VL. The rest of the localization was normal. Here is the angiography. The right coronary artery is not dominant right, but there is some, you see, moderate disease on the proximal, mid, and distal segment. So definitely progression of the coronary artery disease on the right. When you look at this angiography, you can see that on the left side, there was a heavy calcification and close to the stent already implanted. Here is the angiography of the left coronary artery. The left main is quite normal. The ramus is patent with its longer ramus. The stent is here with no critical, no significant lesion within the stent. The circumflex, it's also open with the distal, stent here in the OM branch. And the proximal LAD was, angiographically was not too bad, but we could see the calcification on this view. Then, when you look at this calcification, you see that there is this in the mid, the origin of the mid segment, but in proximal you will see that we have some calcified lesion here. So here is in the cranial view, it's a large LAD. There is a progression of the disease in this at the origin of the thing in the mid segment. The septal branch is correct. The other branches are open. This is the caudal view. Again, you could see the large calcification on the side. Left main is okay. The ramus is there. It's okay. Circumflex. And the disease on the mid and the origin of the distal segment of the LAD. The last view to see you the trifurcation of the left main without critical disease. So you could see that the physiology showed that we have an RFR of 0.85 and in the distality and 0.9 in proximal. When you look at the patient risk assessment, you see here you could see the syntax score as 16, and the syntax 2 score show that we have by PCI estimation of 4-year mortality at 3%, by bypass surgery 1.3%. So the heart team decision and the discussion with the family was in favor of revascularization for PCI. So here we have the the summary of this presentation. Young patient, 45, he is diabetic, he is symptomatic, he has severe calcified lesion on the proximal mid LAD with RFR at 0.85, moderate SYNCAS score, and after the discussion with the family and the patient, the option was PCI. So now we could discuss together the strategy for this patient.
Okay, so as you can see that there's a patient who is symptomatic who has prior interventions and currently presenting with severe stenosis in the LAD with functional ischemia as indicated by RFR. There is heavily calcified LAD, at least in the part of the LAD lesion, with a train-like calcification in the LAD. So how to evaluate and treat this patient? Maybe I start with Khalid. Khalid, what would you do in this particular patient in your daily practice if you see a patient like this?
Yeah, so patient has clear calcification on angiography, and that once you see it in both phases, this is severe calcium. So we need to understand how much calcium, how much circumferential to guide your treatment. So I would do imaging in this patient before I do anything and respond to what I see, what kind of calcium modification, which he's most probably going to have, which device and which plaque modification, strategy balloon, or atherectomy. So imaging, I think it's very important in this patient.
So Khalid, before we move to Roni to ask him the question, I asked you, you said you are looking for a specific imaging findings to guide you in terms of choice of calcium modification. Could you tell us what do you mean by that?
So calcium distribution is very important. So is it circumferential or is it on one side? The depth of the calcium is also important. Whether you have a calcified nodule, which you may change your approach to the lesion, and also the length of the calcification. And based on that, you would, if it is deep calcium, you know that maybe only rotablation alone will not do the job. You want something to deal with the deeper calcium. But if you have only circumferential calcium, you know you can, even with cutting balloon or high NC balloon, high pressure NC balloon can do the job. So those are the things that we look at when we do the assessment.
Ronnie, would you do this case without imaging?
I'm biased, so I'm in favor of imaging. I think where imaging will help dictate, it's a relatively long lesion. The calcification comes back to the ostium of the LAD. So in terms of just thinking about our stent length, in terms of where to land, this is going to give us that information. In terms of the severity of the calcification, one could justify that just looking angiographically, this patient has, by definition, at least moderate, if not severe calcification. You have train track measurements. You can argue it's in two views. You can argue, if you want to be really strict, and say it's probably about 15 millimeters. And so in terms of deciding that this is a calcified vessel, you can comfortably say this is a heavily calcified vessel. So where I think imaging is going to help is maybe help to dictate what are we going to do. In the caudal view, if you look closely, there's suggestion there might be a calcified nodule there right by one of the branches, the diag branches there, that's might dictate our actual equipment use. So I don't think we're debating that calcium modification is necessary, but the question might be, what are the tools that we're going to use and how's that going to help?
Good. So we can go to just for the sake of just moving to the case, we'll just go to the operator strategy. So this is an OCT-guided calcium modification and LAD stenting from King Saud Medical City. The operators are Dr. Ayman Al-Husseini and Hatem Al-Alawi, with third operator Khalid Al-Harbi. The procedural strategy is first to do OCT run for strategy planning, landing zone, calcium modification strategy, orbital atherectomy on LAD, wiring the diagonal, provisional strategy. Obviously, the diagonal is quite long with a severe disease in its proximal part. Reassessment by OCT and decision on other calcium modification techniques or stenting. Third OCT in case other calcium modification technique is needed. They're going to use a 6 French transradial approach, OCT to the LAD, Ultron 2 Abbott, direct wiring of LAD with Viper wire, advanced with flex tip wire, orbital atherectomy they will use, and subsequent OCT, if OCT shows deep calcium. Obviously, they are ready to change any of their strategies according to the image findings. Then they will wire the diagonal, assessment of the result by OCT, stenting and post-dilatation, and final assessment by OCT. These are the operators and the nurses and anesthesiologists in the cath lab. We thank him for being with us today. And with that, we'll go to the case.
Assalamu alaikum. Good afternoon. Good afternoon, everybody.
Good afternoon.
Dr. Hatem, Dr. Alawi, and,
So
we are with you and,
I'm Dr.
in
Hatem,
Dubai.
Dr. Ayman, Dr. Khalid Al-Harbi, our scrub nurse, senior nurse, Vinci, and all the team that is shown on the slides. You are welcome to our cath lab at King Saud Medical City. And we already have listened to the discussion about the case that you have done on the panel. we decided as planned from the beginning to do an OCT assessment of the calcium to be able to plan what kind of preparation. Definitely this lesion is calcified and needs some preparation, as you have said. But the question is what modality of calcium modification is needed. So we started, we have done one OCT run. If you can see it on the screen.
We don't see the OCT run. You can show it. Okay, now we can see it.
It's coming, yeah.
Okay. Dr. Khalid, if you
can make it bigger or okay, good.
You can remove.
Hello, hi. Yeah, if you can.
Yes, this is better now.
Just to explain. So this is the OCT run. So we'll just go through the MELD criteria. So pre-PCI preparation. So we first look at the morphology. So this is the area with the calcium. As you can see here, the calcium thickness is 0.84, and the angle is more than 180. It is 184. So we only have one area, but we have also other scattered area of calcified lesion with the angle around 90%. And then we decided about our landing zone and the distal and the proximal based on either external elastic lamina or the lumen based. And then we decide about the length of the stent. As you can see here from the our landing zone distally and proximally, the length of the stent is 38. The distal landing zone is 3.76. So that's from external lamina to external lamina. So we have to round it down by 0.25. And our proximal landing zone is around 3.42. Because you can see here the vessel is like diffusely diseased. So we barely have a good like distal and proximal landing zone. So this is the only area that we found that
Dr. Khalid, Dr. Khalid,
yes.
Do you have an OCT run? Because it's a fixed image. We see only one.
Yes, we have it. You can run it.
So let's go let's run it from the beginning, please.
And there was a suggestion.
And let's appreciate the distribution of the calcium all the way inside the vessel wall. You will see that we have some areas of superficial calcium mixed with some areas of deep calcium, like here at 7 o'clock. There are some areas of thick calcium reaching even 0.8 millimeters, 0.9 millimeters, with a mixture of, as I said, thick and superficial and deep calcium. There is no definite calcium nodule. If you can come back to the more severe part, please. And if you look here, you see the machine, the AI is mentioning 184 degrees angle, but if you follow the calcium itself, I think it's even more than 180. You have a large arch from 2 to 6 o'clock, and you have another one from about 6 or 7 up to 11 o'clock. And it's quite thick. It's 0.8 millimeters. Go ahead, please.
Yeah.
Run it. Yeah, from the proximal part to the distal. Drag it. Run it, please. Yeah.
Yeah.
That's some deep calcium at 7 from 6 to 9. You see, it's an unstable plaque. If you can look at 11 o'clock, we have a lot of macrophage deposits. A vulnerable plaque, I would say, sorry, not unstable. Go ahead. Continue, please. So given these findings, what does these findings change your strategy
I guess that's it's quite expected to see this amount of calcification with the heavy calcification on angiography, and you clearly demonstrated that's almost circumferential at least one point, where the calcification is really significant. In the so, how did that change your plan, Dr. Hatem?
Actually, I'll stick on my initial plan. I was planning to do orbital on the basics of the angio images. You have seen the angio showed an area of severe calcification. I planned to start with an orbital atherectomy, given the fact that we have some superficial, we have some medial calcification. So I think it's important here to shave, to sand this calcium superficially, and to modify, to crack the deep calcium we have. So it's not a very long lesion to be treated. I think the orbital atherectomy can do a good job from the beginning now, better than to start dilating with balloons and having a dissection. Or, you know, this is a young patient. We don't want to dissect and to have to stent very long.
Great.
Just want
Hatem,
to,
I think we let you go ahead with the procedure, prepare your orbital catheter and show us what you do, and you can remove the OCT from the screen now so we can see what you do. While you're preparing, we'll carry on with the questions here.
Yeah, what we could do, do not hesitate to take the application and send a question, and we will try to answer to all the questions that we will receive here on the panel. Aref, what do you think about this OCT run, the description, what we have seen concerning the plaque, and what will be your strategy for this particular patient?
Well, I'll start by thinking this is a 45-year-old gentleman. We need really, it's a middle AD. We need to be really precise, not to spoil future potential for surgery. So optimizing the results is going to be our objective. So let's say imaging will certainly help us. So I wouldn't go this blindly without imaging. That's one point. The second is now, once we have this piece of information, which showed, as Dr. Hatem mentioned, it is a mixed kind of plaque. There is a deep calcium plus superficial calcium, and the thickness is almost 0.8. So it is indicated to do something with that amount of calcium. And the other thing is, which is going to be disturbing me, the distal part of the lesion showed erosions. So that means we are dealing with some, as you mentioned, also a vulnerable plaque. So taking that in mind, no reflow risk might be also a consideration that I may have to deal with. And with orbital atherectomy, the risk is much less than with the other rota. So that is one technical point I would consider, giving really attention to that. But for sure, by doing sanding or preparing, debulking this kind of plaque will allow me to optimize my dilatation, my expansion of the stent, and the result at the end will be certainly much better without doing this.
Thank you, Aref. Question from the audience, and thank you again for sending question. The first one is OCT showing both superficial and deep calcium. Whether IVL better option than the orbital atherectomy? Question mark.
I think IVL will work for both deep and superficial calcium. And the two modalities that can work for both is basically the shock waves or the orbital, because the orbital has two features, which is shaving the plaque and do the thrusting pulsatility effect. Rotablation alone with deep calcium, I don't think it will work. Always cutting balloon is an option in centers they don't have the shock waves or orbitals. But I would go with the orbital.
Other question coming from the audience concerning the type of device that we could use for this calcium calcified lesion. And they talk about the use of the cutting balloon. Is there an option in this particular lesion or not?
Yeah, I mean, I think, this patient really fits the ECLIPSE trial, where you have a patient that's essentially being enrolled with severe calcified vessel, and you are looking at options of treatment. I think what's clear is calcium modification is needed. I think if you went in and did routine balloon angioplasty and stenting, you might run into trouble after the stent is deployed. Cutting balloon is an option. Scoring cutting are an option, but I think this is going to be one of those cases you're going to need to, whatever modality you choose, you're going to need to validate and verify that you actually have fractured the calcium and you have a compliant vessel before you deploy a stent.
I think we have some technical issues here. So until we get the team
Can
back
we have the cath lab? Okay.
We're back now. Dr. Ayman and Dr. Hatem, we lost you for a short period of time. Tell us what you've done so far.
So we started with the first forward sending.
What speed?
We are focusing 80. So we are starting with the 80.
So what is your technique in doing the orbital, moving slowly up and down?
So yes, of course, I always start with the 80, with the very, very slow motion, very, very slow progression. Go ahead.
If the camera can show you your
1
hand,
millimeter,
please.
1 millimeter per second progression.
Center.
We can send forward. We have 20-25 seconds to do that. Then stopping outside the lesion. The difference with the rota, of course, we can stop it distal to the lesion because we have the luxury of, or the possibility of doing sending backward as well. And that can be really very interesting, this sending backward when we have some tortuosities. This allow us to send on the outer curvature when we are going forward and in the lower curvature when we are going backward, and sending for also lesions, for example. This can be interesting. So I usually I try to follow the acoustic feedback. This, you hear the pinch here. The acoustic feedback is less, I would say, reliable than in the rota. I find it less reliable than the rota. We have more feedback with the rota, with the speed, but it's still reliable. I've done now 2 forward sending, 2 backward. And as you have seen, we have seen some deep calcium. So I think we need to crack it. So these are the 2 buttons. The first button is for the 80K, and the second is for the 120,000.
If you can
RPMs.
center on the device, please.
The drip, please. The drip, please. So you see, when you don't have drip, the machine stops. This is a feature, a security feature. This is a very nice, there are many security features, and it's really very easy to use. I like the brake as well here. It's much easier than, now we restarted the drip, so the machine can restart again. So we are at 180.
Yeah.
And we'll do 1 antegrade run at 180.
If we
Very
can have
slowly.
during the
1 millimeter per
procedure,
second.
the hemodynamics, ECG and pressure, please, on the half screen.
Can you show the hemodynamic, please? What is really interesting with the orbital is the hemodynamic stability that we have. That can be interesting in some patients who are unstable, aortic stenosis. This comes from the fact that the debris are small, and we still have some lumen with the orbital rotation we have with the small burr. We still have some flow in the coronary that can be very helpful in unstable or critical patients. Again, we start
Yes.
again with backward.
Yeah.
Of course, 180, I wouldn't use it in tortuous lesion. Here it's a straightforward.
Yeah, now we can. Now we can hear the sound of your orbital machine.
Yes, you see that there is no more change in the pitch. So I think we are done. We will remove.
Ready?
Open the.
Yeah.
Open it. Just a second. Let me.
Yeah. Yeah. Yeah.
There was a question concerning the size of the device and according to the size of the vessel. How is you
So it's-
select the size of the orbital atherectomy?
Yeah, in a vessel of 3.5 and above, we use 120 speed. Less that, we use we use 80. But what we have seen here is the ideal technique. So this is not like a rotablation. This is, you have to take your time, 1 millimeter per second, and you follow three things: acoustic, feedback, feeling, tactile, and a visual by the angio.
Well, you need to remember one thing, that this is a bare device that rotates in orbital orbit, so it takes, and it's sort of an elliptical train if you move it fast. And if you cause an elliptical train of ablation, you can have rough edges, you can have difficulty. When you move very slowly, you're ablating all the tissue. With regard to the size, the question, I don't know, John, that you mentioned, there's one size, but changing the speed is going to give you a bigger ablation. As Khalid said, for bigger vessels, 3.5 and above, you can use 120 rather than 80 speed.
Yeah, you know, the radius of the orbit depends on the mass and the speed. So the mass is the same. So if we increase the speed, we can go larger, and this can be interesting in large vessels. Yeah. So for the 80K, we can go up to, yeah, from 2.5 to 3.5. For the 120, we need a vessel of at least 3 millimeters diameter, up to 4. So we have only one crown, 125, but it can cover from 2.5 up to 4 millimeter diameter vessel.
Why did you guys exchange the wire?
Wants to explain that.
Yeah, explain why did you exchange the wire?
It's a good wire. Yeah, we can still work on it, but here we will exchange to continue to work. I think we will not need to do more orbital atherectomy. We will do a run of OCT now.
Okay.
Go ahead with the OCT, please.
OCT.
ACT, please, first. Let's do an ACT.
It's surprising because the angiography suspect of calcium nodule was quite high.
Yes.
But the OCT did not see any nodules, right? You see just concentric calcifications.
Absolutely, yes. We have seen some superficial, but it's not nodular, it's not protruding inside the vessel.
OCT.
So now, what is your next plan now? Just to do an OCT before any other balloon dilatation?
Yes. We want to see the impact of our OCT, of our orbital atherectomy on the calcium. And I think the next step will be a regular non-compliant balloon. I don't think that we will have to use a specialty balloon here. I don't know what's your opinion. Probably we will decide on the OCT images. If
Did
we
you
have
have
nice cracking.
a coronary angio after the orbital?
Yes. Can we run below the angio?
Can we have full screen, the angiography?
Angio in full screen, please.
Okay.
So there's already some improvement in the lumen
Yes.
size.
Yeah, go ahead.
What do you think, Aref?
Yeah, I think there is a gain in lumen. We can see that angiographically, but let's see what our imaging will show us. But looks much better.
With regards to your question, Hatem, would you use non-compliant versus semi-compliant balloon? I think there is no penalty to use a non-compliant balloon here. There's always an added benefit. I don't know why would you prefer a semi-compliant?
No,
And
a
this-
specialty balloon. I mean, a cutting or a scoring balloon.
Okay.
Okay.
As you can see here, we are positioning the OCT catheter just distal to the lesion. Then we'll do purge, and then we'll check position.
Buff done. I will
So
engage a little bit more. Yeah, we are in position. Enable. Enable pullback.
let's go.
Cine. Inject. Go.
Okay, so just go there. Bleed.
It looks better.
Just put it in the screen. Okay.
So it's nice to start in proximal from the left main because there are three questions coming from the audience asking to see the OCT image in the mid and distal left main.
Yeah. You have seen the lesion on the distal left main, and there is a lesion in the proximal LAD. If you remember, we have done an RFR during the diagnostic procedure to assess where is exactly the drop of pressure, the gradient, and the gradient was across the mid LAD lesion.
Maybe you can expand the OCT image to have the full screen.
Yeah, just
Can you expand, Khalid Billah, the OCT? Let's analyze it together.
yeah. So
Expand the OCT image full screen, please.
If we can have the full screen.
Yeah,
Okay,
better now.
thank you.
So go ahead. So we see a crack here.
yeah, you can see I can
At
see a crack
11.
here at the 11, and also you can see there is also gain in the luminar area. You'll just reduce the calcium display.
Could you go to the same area where it showed almost concentric calcification in the heaviest segment in prior OCT, so that we can appreciate?
Yeah, can see here
Over there.
there is some crack in calcium at the 11. So we have some good plaque modification in that area. Also, there is also some gain in the lumen. I think maybe
Back
we need
شوية بالله. Little bit back, please. Back proximal, more proximal. More proximal, yeah. What do you think? Here was, I think, the thickest part. You see, this is the 0.8 millimeter thickness. Don't see a lot of changes, actually.
I think it's exactly the same image of pre-orbital.
Yeah.
And it's quite deep. It's thick and deep.
And I think the ultron reading of the calcification is not correct, right? It is probably the
absolutely
one complete arc.
IVL billah. Yeah, IVL 3.5. Yeah. So we'll go with an IVL 3.5 balloon. It's deep.
IVL.
I think it's a little bit. Yes, IVL, please.
Can we see the OCT image in the ostial LED and the mid left main? Is it possible?
We need to repeat it because we reach there.
Come back to
let me just check if we can see.
Proximal.
Here we have the lesion in proximal.
Shockwave, Billah. Shockwave 3.5. 3.5.
And this coming. That's a plaque here.
Yeah.
So what do you think in the panel? We have done orbital atherectomy. We have now the image of OCT. What will be the next step?
We have seen
They prepare IVL.
Yes.
In your cath lab, what do you prepare?
Well, we have seen some cracks in the most proximal part of the lesion, and most probably the calcium has been shaved. The thickness of the calcium, I'm sure it's less than when we started. I would use a cutting balloon after this. So we do a orbital cut and then see how it goes.
Okay, cutting balloon. Ronnie?
Yeah, I mean, I think we see we see some plaque modification, but I'm concerned it's not enough. I mean, one option is to just do more orbital atherectomy, just go back in and do another round. We haven't just challenged it with an NC balloon. I think an NC or cutting balloon would be reasonable as a next step, but I think it's reasonable to do more atherectomy as an initial choice.
Okay. RF?
No, I would go preferably with IVL as the operator. I think this is too deep for touching it again. So probably IVL will be ideal now to do some modification with the deep calcium.
Related to your answer, RF, there was a question which was the following: how would the orbital atherectomy impact deep calcium? That's a question coming from somebody in the audience.
Yeah, one of the features or the mechanism of the orbital is pulsatile effect. So it's not only shaving, it has some pulsatility, so it can fracture deep calcium.
So when we have deep calcium, this is another question, which is the following: maybe IVL upfront for cost purposes in view of calcium depth. What do you think?
Could have been in this situation, could have been. I mean, the lumen was not that bad, but it helped us with the superficial calcium. We did some job there, so it's not without. So I think we debulked a bit of the calcium.
You'll be in favor to combine both?
Yes, I think that is an ideal strategy in this.
Okay. Other comments on the combination of both techniques?
I have very low threshold to combine. So when we do either orbital or rotablation, I always combine it with another modality to get the best result.
Okay. Ronnie, same?
Yeah, I mean, I still think it's reasonable to challenge with an NC balloon just to see what we're dealing with. That might actually, if there are some micro fractures in the medial calcification, there's been no pressure that's been applied to the vessel yet.
I think the main aspect of this LAD calcification is the deep calcium. That's where we're seeing the two layers of calcification on both sides of the LAD. I mean, this is clearly deep, even by angiography. You could see it is deep. And obviously, at that particular location, orbital had done little at that particular deep calcium location. So I think IVL is the go-to procedure at this time. Would be nice to see what happens to the balloon of the IVL. See the waist and see the waist goes away as long as you keep
What is
shocking.
interesting is when we saw the angiographic result post-orbital atherectomy was not too bad.
Yes.
In the cranial view, everybody agreed to have to see that we have a nice opening of the vessel. And then when you look at the OCT result, it's a little bit disappointing.
But John, the best view of that calcification is in the areocaudal.
That's true.
We did not see that one after
yeah.
orbital. So
That's true.
I do think
Second one.
where do we think about in terms of decision making with cost and opening up different devices? Because of course, if we used 2-3 modalities, we can probably lesion prep, but some centers are not going to have access to multiple things. So what would a center do that if they don't have multiple modalities or cost is an issue in this particular case?
you start with IVL. I mean, if that is one thing you will use, I mean, obviously this is a deep calcium. Then if you have to, think of cost, IVL was bulky balloon and it would not go sometimes unless you do some orbital or rotational before using the, sometimes you're forced to use both modalities.
But if you take into account the result presented by Thomas Cuisset this morning with different studies, randomized trial comparing balloon, OPN balloon or NC balloon on one hand, and on the other hand, all the modality of atherectomy, it was really impressive to see that the good result obtained with OPN balloon. So maybe in this particular case, following the orbital atherectomy, we could complete with an OPN balloon. That could be another option.
If you look at the Eclipse trial, the crossover rate on the orbital side was less than 3%. On the angioplasty side or specialty balloon side, it was around 4%, a little bit plus. So your crossover rate is quite low if we look from a trial-based perspective.
I think your IVL balloon slipped backwards.
Yes.
Yeah, yes. Slowly.
But it opened quite nicely at low pressure.
Mhm.
What's the pressure now?
I'm at 4 now. I think we'll need to move a little bit more down, but we'll go at 4.
It's not too bad.
0,
Mm-hmm.
6.
One thing that we don't see clinically anymore that we used to see in the past, the
Push a little
perforation
bit
of
more
the
Yeah.
down.
after we have started
that's
using
good.
all those modalities, it's really very unusual to see a perforation. So by managing
4.
calcified plaques.
So Ibrahim, the balloon opens very well before even the
Before the shocks, yeah. This has surprised me actually because
which means orbital worked.
exactly. Despite the OCT did not show any cracks in the deep calcium.
See, we have still some waste on the balloon.
Yeah.
The balloon slipped means as well that we have still a significant lesion. Pressure, Billah?
We
Around
appreciate the calcium better in the RAO projection. Maybe
Yeah, can we
areocaudal-
go down in the areocaudal, Billah?
Yeah.
Yeah.
Are you centralized more on the areocaudal? Yeah. I think we can go back now on the proximal part of the calcium.
Yes, too deep. Now you can see both sides of the calcification.
Yes. Absolutely.
See,
Or-
that is where the
You see
The
where
waist-
is, yes.
waist is. And if you
So
go
it's-
even more proximal, I think you will see more waist in the
Yes.
balloon. But you can ablate here.
Absolutely.
You can deliver the shocks here.
6. Down. So we'll centralize on that zone where there is the waist.
Yeah,
Okay, that's great.
this is the perfect position now.
4.
I didn't see. Tom Johnson is here in the room.
Yeah.
Can we take
You
the
see if we have
microphone?
put a stent there without any, I don't know how we'll open the stent there without more modification. 6 down.
Just 1 second. Huh?
There is some.
We leave some time to get more coronary perfusion. Okay. Pressure is good. Okay, back again.
Yes.
So we can do
4.
during the balloon inflation.
Still resistant, huh?
Tom, you can comment. You send us a very nice comment on the by application, so we could share with all the audience. Thank you.
I mean, it's a beautiful demonstration of us blending the information we got from the angiography as you presented, Jean, at the beginning, and then the imaging. And I think the challenge was that we expected to see more calcium than was evident on the OCT. And possibly that's because it is deep wall. It would be interesting to do a clear stent or a stent boost at this point, again, just to see exactly how deep that calcium is located behind the balloon. And it may have been that with the imaging that we got in relation to the angio, that just taking a non-compliant balloon or a cutting balloon would have been sufficient. I mean, Khaled says the orbital has made the job of the IVL easier, possibly, but it's equally possible that just a normal balloon would have been sufficient. We won't know because we can't test it. But my interpretation of the first OCT was that maybe just taking a non-compliant balloon would have been enough, but we can't tell unless we adopt that strategy. But we know from Eclipse, as Ronnie's mentioned, that there were challenges in that trial, but that was because the inclusion was based on severe angiographic calcium. And what we see here is actually calcium that may not be impacting the expansion of our devices because it's deep wall. So ballooning and stenting may be enough, but the important thing is to repeat the imaging to assess what we're seeing by expansion of balloon in orthogonal planes against what we see by the imaging before we contemplate deploying a stent. That was my comment.
Thank you, Tom.
I will go more.
I think from the you delivered how many shocks so far?
So we still have
30
remaining
And it seems that
from 120.
go up here.
it seems that the balloon had opened the waist better than when you started, but there's a still
Yeah, but it is still
some waste.
Still,
Yeah.
yes. Absolutely.
Yeah.
Yeah.
There's a stent plus the plaque. And the stent is certainly proximal, I think, to the
6. It's not opening
Not open.
perfectly, actually. I'm not happy putting a stent without going more aggressively. Okay.
Yeah.
Still remaining 2. I don't know how efficient will be these 2 last runs. We'll take a cutting, I think, but it's quite deep. I don't know how efficient will be the cutting here.
Why don't you take a regular MC balloon 3.5 and see how it behaves here? Because obviously with the
We can try.
shockwave balloon is
Yes.
quite low pressure.
Yes.
Yeah.
Yeah,
Yes.
the last. Prepare a 3.5, please, NC balloon.
So there is a lot of question coming from the application on the different sequences, orbital plus cutting, orbital plus NC balloon, orbital NVL, without orbital, just IVL, etc. So we will come back during the discussion just at the end of the case.
Mm-hmm. I think it's good to get an angiographic view
Small
after you've done that
now.
prior to any ballooning, just to appreciate. We have on the other side of the screen your prior,
Let's go Cine.
يلا سني checked.
definitely an improvement.
Geographically it doesn't sound bad, but I'm not happy with the opening of the balloon. I think we need to go more either with cutting or as you have said, with an NC balloon. So let's take a regular and non-compliant 3.5/15, please.
Mhm. 3.5.
Carefully, because it can slip. So if it slips, I will change to, we'll go very, very slowly.
Definitely, the lesion has been modified quite nicely, but not optimally. And
Yes.
as you said, you risk putting a stent here without fully achieving a good expansion with the balloon, because then you're going to have a
he's young.
more difficult situation to treat.
Yeah, absolutely.
So there is a question concerning the pressure that we place in the IVL balloon. First, is there a limitation of pressure? Second, is there an impact on the effect when we increase the pressure inside the balloon?
Well, we have the limitation. Actually, 4, according to the company and the industry, the 4, and then you go to 6 and you go down. And we've done sometimes we go up to 8 or 10, even atmosphere higher, but that won't help much. If you need to, you go with NC balloon afterwards, and that will be ideal.
Same comment?
Yeah, 4 and 6, I wouldn't go higher than that. Because it should be 1-to-1 sizing. So it should be well opposed to the lesion to deliver the sonography.
Actually, if you break the shockwave balloon, retrieving it is difficult. I don't know, it's quite bulky balloon, and somehow if you break it, it's difficult to retrieve. This was the NC balloon, Hatem, right?
So it's, this is an NC balloon 3.5/15. We went very slowly up to 20 atmospheres. I appreciate that the opening is a little bit better, I would say, than what we had with the IVL. Probably with the stent, with the radial force of the stent and an aggressive post-dilatation, we can overcome that.
Yes, I think it's a good expansion of the NC balloon. Much better than the IVL balloon.
We are at 20, some chest pain. معلش عمر معلش. عمر بننفخ البالونة في some chest pain, don't worry. يلا. What do you think? Another OCT? I don't think that we will add any other data or more information with a new OCT. I would go with a stent cutting, but it's quite deep for a cutting. I don't think that we'll be able to modify anything with the cutting. Any other opinion regarding that?
First, we could have the angiography control.
Yalla. No bubbles. I'll prime just a second.
Oh, 1 minute. Okay. Yalla. Prime. Yalla.
Sine.
It's not too bad. Huh?
Not too bad.
Yeah.
Okay, let's go and stent. We'll post-dilate if needed with an OPN. Yalla, 3.5. It was a 3.5/38, I think.
Okay, actually,
Yeah, it's based on the OCT measurement. So we have the length of 38 length, and distal is 3.87 eel to eel. So this is how we decide about the length of the stent.
Look at the length.
Okay, 3.5.
I mean,
38 stent.
we used to accept some residuals sometimes in such calcified breasts. I mean, why do we aim the 0? Okay, that's fine, but sometimes you respect the calcium amount, that part. We don't need to exceed with the pressure, everything to make it straight line. I mean, 10%, 15% residual is fine.
Question?
معلش.
Can we have the microphone working?
So what size of a stent you're taking in?
So it's a 3.5/38 based on the OCT measurements on the EEL distally.
What
We
stent?
had
Zions?
it's a Zion SkyPoint. It's a Zion SkyPoint. So a 3.5 that can go approximately to accommodate the large proximal segment.
Okay. Go ahead, please.
I have a question for Dr. Hatem. Are you willing to
cranial,
modify the
please.
distal calcium just before putting your stent? Because
So what was the question?
I mean, for Dr. Hatem, would he do a modification for the calcium just at the distal part where he's planning to put the stent? Because I feel there is some room to modify it a bit.
Yeah. Yes.
I didn't understand.
think it's
So
more
your
distant.
question is more modification of the calcium. Yeah.
Little bit more down, please.
Mm-hmm.
I think distally it's
Good.
okay. It's not so bad.
Yes.
Go Sine.
That's okay.
Yeah.
That's 3.5.
3.5.
I think we can go a little bit more down.
Yeah.
I think it's short. It's short. Yeah.
Sure.
Dr. Ali,
We
please.
change it.
I'm just wondering if he did not modify the calcium, let's say, fully, why don't you just do DCB? I mean, it's probably safer in this case.
It's not
Because
that they didn't-
if,
they
if you
did not-
don't, if you didn't, I mean, there's chance of stent restenosis. So you could do DCB and then see what happens instead of putting a stent.
I guess now that they answered your question. The expansion is quite nice.
We have to go to the caudal view.
The caudal view, yeah. Maybe we have a caudal view when the balloon is inflated.
Yes. معلش.
The poor man's. There you
There's
go.
some chest
There you
pain.
go. Because some skeptics in the room are talking about other modalities, but it looks like it's a bit.
Opening well.
I'm not sure if we're in the lesion or the stent is in the proximal inlet of the stent is within the calcified lesion, right?
Edge. Yes. Yes. We'll
I
post
hope-
dilate with a 3.5 and we will do an OCT to see if our landing zone really was good or we need to complete proximally.
Can
if
we see
are
an
missing.
angio and the caudal projection, please?
Sure. Ready?
I'm priming.
Yeah.
Looks it's okay.
Looks not bad. Let's post dilate with a 3.5 distally
yeah, it's
and
covered.
a
I think
3.75
it's covered.
proximally.
The lesion is covered.
Lesion is covered, yes, but you
That-
still have a
It's covered.
minor waste.
Yeah. That's a reason it's important to use angiography. I'm originate from the old generation of angioplasty, but I strongly first in angio, then I'll complete with imaging, but not the opposite.
So, John, when we measure the length by
Go
imaging,
cranial, please.
so we know the length of the what should we cover, but when we go and actually in the angiogram, without a co-registration, you cannot be sure you're at that point that you measured from.
Sure.
So sometimes you will be short of the lesion because you're not exact at the same points.
That's where it's really necessary to use exactly the same view from the reference to the result and not changing the view. In other words, you select areocaudal, the same areocaudal, and then when we select the AP or areocranial, you have to select exactly the same one. And then you could. If you change, it's impossible. That's true.
Do you have a stent boost?
7.515. Yeah, we have done stent boost. Just
Maybe you could do it. And I
Before-
think the caudal projection shows the waist more than
Yes.
the cranial.
Sure.
So you could
20.
do a stent boost.
How we go for that?
Areocaudal, please.
In caudal.
Cool.
Centralize. Boost.
Yeah, just
I think we are outside شوي هنا. No, beautiful.
Yeah.
We are on.
the sequence of the different devices.
Mm. 22.
Sometimes,
Do a
sometimes,
run of OCT.
yes, a good time for the OCT now. We used to say in the good old days, Jean, the perfect is enemy of good, right?
Sure.
So sometimes accepting a reasonable result.
ACT بالله. ACT syringe. OCT. Yeah.
You can accept that.
Yes, exactly.
Okay, let's go to OCT.
He's receiving
Yes, go ahead.
Yeah,
please.
interesting
BP
case.
is high.
Can we get out with a drug-eluting balloon rather than putting a stent in this scenario if the OCT is reasonably fine?
Say that again. Drug-coated
Can
balloon?
we go with a drug-eluting balloon rather than a stent in this scenario?
Yeah, that was a question raised
stenting.
by your colleague here, and that's absolutely an acceptable strategy as well. But the stent is already gone
I think
in.
as a result, yeah, the result was not, the residual lesion was more than 50%. One of the primary criteria to treat just with a DEB is to have a perfect, good DEB result. It's not only a question of dissections, I think. I was not happy with the result of preparation and the result of the residual lesion. That's why I decided to put a stent.
Actually, to the
I don't think that a DEB alone could make it, leaving a 50% lesion or more. Yes, sorry.
I mean,
I can hear you.
The drug-coated balloon trial lately announced the subset of patients with calcified lesion did better with the DCB. So.
Doesn't go.
Go, but slowly.
Depends on the criteria of inclusion. That's right.
You're having difficulty in getting the balloon in? Oh, that's OCT, sorry.
The OCT catheter, yes. Yeah. It's difficult to go.
Yeah, mildly, but it will go.
They have difficulty to advance.
I think pulling the wire, pushing the wire might change the bias, the device, and you could get it through.
Absolutely, yeah. Okay. Okay, great.
Yes, better now.
More distal شوية, distal to the, we still have some struts if you can.
Yeah.
Can just a little bit.
Yeah, sure.
Just now
Okay. Good.
checking the position and pairing and also checking the engagement. So we have to have a good opacification of the OCT.
Can you engage more, بالله أيمن? Engage more, please.
Yeah.
More. Okay, it's okay. Let's go. Enable pullback. More goes بالله. Sine, go. I think we will focus on the proximal part.
Yeah,
I think distally we don't have dissection. We are not covering the distal part with our OCT. We had some difficulties to progress. But we will be able to assess the calcified lesion, the expansion there essentially.
Yeah.
And if we have any geographic miss proximally, as suggested initially.
Okay, good.
So we have 87% expansion. Yeah, go ahead.
Yeah, so we are just looking at three things. So we are looking for the dissection, especially in the distal edge. So here there is no dissection, as you can see here.
You
in
can
the
go more distal.
and as you can see here, there is no distal edge dissection. It's not that clear. So we are at the distal end of the stent, and also proximally we can't see any edge dissection. And then we'll look for the malposition and the expansion.
Nice.
As you can see here, or maybe we'll just go from distal to the proximal.
That's correct.
Okay, great.
You can see here over.
I think I am over.
Yeah, you can see here.
It's perfect. We'll repeat the run.
It is 86% expansion.
Dr. Khalid.
Yes.
Can we repeat the run because we don't see the distal edge of the stent?
Yeah, maybe we'll just repeat the run. Yeah, because you can't see the distal. So we'll just go more distal.
Enable pullback. Cine, inject, go. Okay, I think it's a better pullback. We can see distally. I had a doubt in the distal edge of the stent. Need to be more sure about it. We can remove the.
Yeah.
128 contrast till now. So distally.
So now we can see the distal. We have some swirling there in the distal part, but we can't see like any distal edge dissection. Yeah, there is no distal edge dissection. You can see here the expansion all over the stent is like above 100. So it is expanded and very well opposed there in the distal part. All we have gaining the good expansion all over the vessel. It's all like above 90, which is an excellent expansion of the stent. You can see here there is some swirling.
There is some malposition in the proximal edge. Here, I think it's some bifurcation.
Here there is some opposition, malposition at the proximal part of the, or at the mid part of the stent. I think this is the area where the calcium is more prominent on the pre-PCI.
I think it's an artifact, Khalid. What do you think?
Let me just check there.
Yeah.
Yeah, it is. I don't think that's because this is a lot of swirling. I don't think this is true malposition because you can see here the dot. It is in the swirling part, but I think this is our lumen. I think that is my mistake. But
yeah, there is no shadow behind it.
Yeah,
so.
Yeah, there's no shadow, and I think it is calculating the swirling there.
Yeah, I think
also here you can see swirling, but I think it is fully expanded and well opposed on the vessel wall.
So AI is not catching up with your eyes yet.
Yeah, absolutely. I think still there is some limitation, so we have to depend on ourselves because if the AI took our place, so we'll have to quit our job.
Can you remove the AI, Bilal?
I guess we go with the final shot in the RAO projection, RAO caudal.
Yeah. Let's go in RAO caudal, please. I think we don't need to have the wire. We don't have any dissection down, so we can make it single last scene.
Can you have the angio on the screen now? If
scene?
Yeah, angio on the screen.
The big screen. Okay.
We still have that calcium. I think it's a deep calcium that is not impeding the opening of the stent. The MLA there, the MSA there is not restricted. Is not bad.
Yes, I think this is a good result. Good, acceptable result. I think doing more here is more harmful than useful.
Absolutely. Yeah. We still have some options to go with an OPN, but as you have said, we can complicate things here.
No, you did a great
you
job.
can see here it is without AI. So as you can see here, this is the area. So it is above 80. So it is acceptable expansion here. So this is without AI.
Good.
8 millimeter square, 8.8 millimeter square.
Just, any thoughts on the LED flow itself relative to the rest of the coronary tree?
Just the apical, it's the same as before. As you could see that the one on the other side is the same.
Can you see the diagonal?
And the diagonal.
Yeah. Go back, Bella. We still see that diagonal. We decided in the beginning to wire it like after the...
Okay, so...
Can we see the cranial view, Bella?
So, gentlemen, Dr. Hatem and Dr. Ayman, thank you very much. You've done a great job. And thank you very much.
Thank you so much.
Thank you.
Thank you.
I guess we go to Ronnie, your presentation. Now, Dr. Shantouf is going to tell us about atherectomy, rotational versus orbital. Hopefully, he's going to add a lot of wisdom here.
Thank you very much. So let's kind of dive a little bit deeper in regards to orbital atherectomy and how this fits into the whole process of calcium management. Why is calcification so important? One of the key things is really thinking about the impact it has on not only your procedural success, but also outcomes. And so when it comes to procedural complexity, thinking about the ability to deliver a device and device failure is actually impacted by the amount of calcification you have. It might impact the ability for you to deliver your balloons, your stents. You're going to end up with stent under expansion, which is really the strongest predictor of stent thrombosis or restenosis. And you could end up with vessel injury with increased risk of dissection or perforations. In terms of outcomes, we're really thinking about increased MACE outcomes, specifically higher rates of target lesion revascularization, so clearly related to the vessel that you were working on, increased periprocedural MI, and higher late stent thrombosis rates. So in essence, severe calcification is going to put you at increased risk for PCI failure in severe calcification and increased risk of MACE when compared to non-calcified vessels. And so what's the role of intravascular imaging? I don't think you can talk about debulking or calcium modification without at least having an understanding of intravascular imaging and making a decision of when you are or are not going to use it. In terms of imaging, it's really critical in calcium assessment. It really helps us determine the whether or not our calcification is superficial or deep, as we saw in today's case, whether it's concentric or eccentric, the morphology itself. Do we have a nodular? Do we have sheet-like calcification? And of course, the burden itself, whether the length, looking at the arc, and looking at the thickness itself. In terms of clinical and procedural benefits, it helps us confirm, after we've started intervention, intravascular imaging helps us confirm calcium fracture and modification, that it took place and it took place enough that you can move forward. It also verifies adequate lumen gain, which of course is going to affect our MSA goal and will help us assess the final stent expansion and apposition, looking for complications such as deep medial dissections. When we looked at the ECLIPSE trial, the IVA, or the intravascular imaging sub-study that was designed, this was a trial published in 2025, we saw a 26% reduction in one-year target vessel failure when compared to intravascular image guidance versus angiography alone. So what about defining severe calcification? Really, when we think about it from fluoroscopically, as we were talking about today, it's really looking at the length of the calcification, but more specifically where the location is, and does it run along the tracks of the artery? Do you see it on both sides? Do you see it in two different views? And what's the length in and of itself? In terms of IVUS, we're really looking at the arc of the calcification, the degree of the arc of the calcification, the length of the arc of the calcification, and also where it's present in the vessel, and is it present in areas where the diameter is actually small or relatively small, and whether or not we have presence of calcified nodules. OCT has a very similar but slightly different take in regards to where the data is. So it's looking at the calcium thickness. Do we see a calcium that is greater than 0.5 millimeters in thickness, or even 0.3 at looking at some of the latest data? And the calcium arc itself, are we seeing more than 90 and specifically more than 180 or even 270 degrees of calcification? And the length of calcification that we have. There's actually a score system that's very nice that one can use and mentally use, and when it's looking at the IVUS and OCT scoring, which really takes into considerations these aspects. In terms of tools, so we've already figured out we have severe calcification. Now we really need to think about the tools that we have available to help us make that decision. And of course, there's a lot of balloon-based technology, simply non-compliant balloons, cutting, scoring balloons, OPN balloons, high-pressure balloons, atherectomy or debulking devices, but also calcium modification devices such as rotational atherectomy, orbital atherectomy, and laser. When looking at calcium modification, not necessarily debulking per se, but intravascular lithotripsy, and of course hybrid strategy, what we saw today, where you're actually combining multiple modalities into one. What I think is important here is really thinking about it in a logical and algorithmic way. So one is assessing the calcium, making a decision mentally using the data that you have, whether it's fluoroscopically plus or minus imaging, and deciding on the severities, figuring out the crossability of it. So not only do we have to decide in regards to the modification, but can we get the tools that we want there to the right location? I may want to use IVL, but I can't get IVL to the location that I want to use it, for example. And so selecting the right tools based on what we're dealing with anatomically is going to affect us. And of course, we're really focusing this talk on the anatomical considerations, but we have a whole other layer of clinical considerations. Of course, our patient, how's their EF, what's their morbidity and mortality in terms of risks itself. And afterwards, we need to confirm the effect. And so this is where modification tools help. So let's focus a little bit in on orbital atherectomy and kind of dial in a little bit about what this device does and what the benefits and the tool specifications have. So it's a 1.25 millimeter crown. That's the size of it. It's a one size in terms of the coronary. It has two different speeds 80 RPMs and 120,000 RPMs. So 80,000, 120,000 RPMs. So you can switch between the two speeds. The coating itself, you have a diamond coating that has 30 microns and 10 microns that get exposed, as you can see in the left side of the screen. It goes over a specialty wire, the Viper wire, which is of course part of the kit. And when we think about what it does, it really provides bidirectional sanding as part of it. What this does is the crown rotates in an elliptical fashion. Not only does it sand the superficial calcification, but the elliptical orbital motion and the pulsatile mechanics of it allow for fracturing of the medial calcification, which really gives it a dual action or sort of a dual modality. So one is modifying the intimal or superficial calcification. Two is really looking at the fracturing of the medial calcification. In terms of safety, there is some thought that really because of the orbital nature of it, as opposed to, for example, rotational atherectomy, you're not occlusive, and this allows for blood flow to continue, was one, and two, the particle size that gets, the ablative particle size that get created are 2 microns, which are essentially less than the size of the red blood cells. So you have a theoretical, and some data suggest a clear reduction in terms of distal embolization risk compared to some of the other modalities, specifically rotational atherectomy. So how do we deal with orbital atherectomy in terms of approach? We want to think about it from a pre-procedural setup. So of course we want to think about, we already know our crown is one size, we have a specific wire. The orbital ablation sequence, you've already decided you need the device. You're going to place your wire distally, typically start with a low speed, and you're going to judge that based on the vessel size and the impact that you have on the low speed. What's important is you want to rest in between, so up to 30 seconds in between your treatment time. So if you're going to go about 20, 25, 30 seconds, you really want to stop at 30 seconds. Pause for the same, one simple way to think about it is pause for the same amount of time that your ablated time that you've done. And don't go over a total time of 5 minutes in terms of the recommended guidelines. High speed is really reserved for if you have a larger vessel, 3.5 and above, and you really feel that you need to continue to modify specifically sometimes the medial aspects of the calcium. In terms of technical tips, the advancement rate, so those that are used to rotational atherectomy, it's going to be a different motion. You're not having that same pecking motion. You're really applying a slow, smooth forward and backward motion, 1 to 3 millimeters per second. Yeah. And you have the glide assist, which will help you at a low speed, 5,000 RPMs, to be able to move the device in and out. Fantastic. One sort of technical advantage is the ability to do bidirectional sanding, so you can go beyond the lesion and work your way back. This is nice in consideration, for example, for osteal left mains, which are very difficult to sort of approach from a rotational aspect. So if we're going to compare the two devices, because we think of them the same, they are similar, but they have different approaches. The mechanism of action we talked about in terms of sanding versus high ablation speed. The speed ranges of 80 to 120 versus 140 to 180. The force and the surface sanding are going to be slightly different. The wire bias, you get a little less wire bias because of the orbital nature of the motion. The vessel size flexibility, of course, one crown as opposed to picking up crowns. However, of course, rotational atherectomy, a lot of times we use one crown, one burr at this time. And in terms of the safety profile, there is some suggestion that with a continuous blood flow, you have a little less there. And so I just want to wrap up in one slide in terms of how to think about it. The European consensus, this is a nice consensus paper that came out. I modified it by adding a little bit of the SKY expert consensus that was in 2024 and the 2023 and sort of combined it. So I think the first part of the algorithm is deciding, do you have severe calcification or not, based on angio plus or minus imaging. In this case, let's assume we're doing imaging. Do we see the marking? So we have the imaging over here. You do imaging, and what does it show you? It says, yes, I do have severe calcification based on our score system, whether you did OCT or IVUS. At that point, you're going to dictate. It's going to dictate your approach. If you do have severe calcifications or concern, you might want to take a more aggressive calcium modification approach, which might include lithotripsy, rotablation, or orbital atherectomy. I'll throw in scoring or cutting because I think it has a place in terms of thinking about it from a modification, bringing that in from Sky's thought point. If it doesn't meet that criteria, then maybe sort of your routine approach of non-compliant balloon plus or minus moving forward with that. Now, if you've decided that the imaging catheter cannot cross, not decided, but the vessel decided for you, then you want to look at really the crossability of a small balloon. Take a small balloon, try to cross it. If it is able to cross, pre-dilate, and then come back and do your imaging. If it is unable to cross, you're really at a point where you have to make a decision. You need to debulk. So things like IVL are not going to work. As much as you want to use it and it's a friendlier device, you want to look if you can cross with a microcatheter. Otherwise, you really got to look at an ablative approach, a rotational atherectomy. I'll throw in that orbital is possible. There's some nice data to suggest that this can be an approach, although typically we think of it from rotational. If you can't cross with a microcatheter, we're really looking at laser device. You want to ensure calcium fracture, as we talked about today, and then move on to the next step. You've decided you've actually modified the plaque enough, and then at that point you can move forward with stenting. For the sake of time, we'll skip in terms of that portion. And of course, if necessary, to do a hybrid approach. And so with that, I think I'll stop there. We kind of did a quick blizzard of atherectomy and how it fits into the bigger picture. Thank you.
Thank you very much, Ronnie. So it's time to, we are perfectly on time. And first of all, I would like to thank Abbott to give us this opportunity to share the following question, in other words, how to treat this heavy calcified lesion of the LAD. And it was really interesting to see the place of imaging, particularly OCT, in this particular case, showing with precision all the characteristic of the plaque, and particularly to see the main difference between superficial and deep calcium. The second point was the need for plaque preparation and optimal plaque preparation. And this particular case, we used orbital atherectomy plus IVL. There is a lot of question on what about the right sequence using multiple modality of atherectomy or aggressive balloon angioplasty. And the third was the stent implantation following by the nice pulse dilatation. And finally, the assessment of the final result angiographically and by OCT with this really good final angiographic result. So I would like to thank first the two operators, Einman and Hatem, and second, all the panelists here. Of course, my friend Ibrahim, Aref, Khaled, and René. Thank you, all of you, for all these multiple questions coming by the application, and wish you a nice end of the day. Thank you.